Good afternoon, everyone. Welcome to everyone, all the attendees. Thank you for being able to attend today's important webinar. My name is Manasi Jayaprakash, and I'm the Manager of Quality Improvement at Illinois Primary Healthcare Association. For those of you who are not aware of us, since there are both IPHCA members and non-members who are ICAP members attending this webinar, we, that is Illinois Primary Healthcare Association, are a non-profit member-based association with community health centers, also known as federally qualified health centers, as our members. We represent 46 organizational members, with most of them being in Illinois, and with additional 2 from Iowa and 1 from Missouri. Specifically in Illinois, there are 44 FQHCs, or community health centers, that serve close to 1.2 million underserved patient population across 360 sites. And close to 80% of these health centers are established patient-centered medical homes. We are very proud to represent FQHCs in the state of Illinois. There's more information on our website if you're interested at www.iphca.org. IPHCA is hosting 3 webinars for its member health centers. Today is the first webinar out of the 3 and is co-sponsored with the Illinois chapter of American Academy of Pediatrics. And today's topic is very relevant, which is latest childhood immunization guidelines and addressing vaccine refusals at community health centers. And again, thank you to all the attendees who are able to attend today. We are also thankful to ICAP for their continued support and partnership. Today's event is made possible by funds received from the Office of Health Protection through the Illinois Department of Public Health. I would now like to introduce our speaker, Scott Goldstein. Dr. Goldstein is a general pediatrician who's been practicing in Chicago for 10 years. He was born in Maryland, attended college at Northwestern University, received his medical degree with honors from the University of Illinois, and completed a pediatric residency at Brown University in Providence, Rhode Island. He's spoken to many parenting groups and local and national media on a variety of topics and has been speaking about vaccines for the last 7 years. He lives in Chicago with his wife and 3 children. Dr. Goldstein, again, thank you very much for being able to speak to our health centers and ICAP's members. And the stage is now yours. And I'm sorry, before that, if there are any questions, attendees, please feel free to use the chat function, and we will reserve the questions after the presentation. Thank you, Dr. Goldstein.
All right, thank you. Thanks for having me talk today. So we're going to be talking about the latest childhood immunization guidelines and then addressing vaccine refusal. So one more scientific part of the talk and then one more on just communication. The first part of it is just kind of cut and dry, what we're doing with vaccines, what we're giving them for, common side effects, things like that. The second part is going to be more about how to deal with issues that parents tend to bring up. And this is that comes from a talk that I put together now probably almost 10 years ago when I started talking to parenting groups about vaccines. People tended to be much more hesitant. I feel like in practice we're seeing less hesitancy now than we used to. But and I used to give this talk frequently to parents on why they were refusing vaccines and what the medical that's giving them was. And it's been maybe a couple of years ago, my talk got less popular. The talk that I gave at Northwestern got less popular for parents than the talk about how to introduce your dog to your newborn baby, which that was something that was consistently selling out, and I was talking to like 5 or 10 people, and so my talk became less needed, which I think is probably a good thing. It means maybe we're doing a better job of communicating to parents. So anyway, just to get started, I have no financial relationships, and I'm not discussing any unapproved investigative use. What we're going to do, like I said, talk about the 2016 ACIP recommendations for routine vaccines and talk about approaches and communication strategies that providers can use in clinical settings to improve vaccination rates. And then at the end, there'll be some resources and time for FAQs. So starting off with the importance of vaccines. There are many serious vaccine-preventable diseases that are still circulating in the U.S. and globally that can have serious or fatal consequences for children and adolescents. And ensuring that all kids receive the complete series of each vaccine is important for a couple of reasons. First, as healthcare professionals, it's our job to prevent illness in patients whenever possible. Vaccination has the benefit of not only protecting people who receive the vaccine, but also those who may not be able to receive the vaccine, including people who are too young or too old to get vaccinated, or immunocompromised people whose immune systems can't tolerate certain vaccines. These vulnerable groups rely on a well-vaccinated population to stay healthy. There are also some less tangible benefits to childhood vaccination. Some vaccine-preventable diseases are acute, while others can cause chronic disease, and all can cause chronic long-term health complications. The burden of all this illness on the healthcare system is huge. Keeping people healthy can save a significant amount of money. There's also a time and emotional savings to keeping people healthy. When a person, especially a child, gets sick, they're not the only ones affected. Family and friends have to help the sick child with doctor visits, treatment plans, daily activities. There can be an emotional toll on family or caregivers as well, particularly if someone they care about contracts a serious or fatal illness. Vaccines are among the most successful and cost-effective public health tools available for preventing disease and health. They not only protect vaccinated individuals, but also protect entire communities by preventing and reducing the spread of infectious disease. This is the complete recommended immunization schedule for children and adolescents up to age 19 that's put together by the ACIP, the Advisory Committee on Immunization Practices. The orange bars represent the optimal timing of administration for each vaccine. There's also a catch-up schedule, or if a child falls behind, there's a catch-up schedule in green. Purple bars indicate the recommended age range for certain high-risk groups. This is the catch-up schedule for any children who may have started their immunizations later than recommended or who have not completed the series. This table shows the minimum amount of time that's necessary to wait between each dose in the series of immunizations. I want to just talk briefly about the concept of cocooning. Babies younger than 6 months are vulnerable to many vaccine-preventable diseases because they're too young to receive all their vaccines, and they have a higher rate of infection and more serious outcomes for some diseases. Cocooning refers to a way of protecting babies from these harmful diseases. Older children and adults are the primary way that babies get infected. Whooping cough and influenza can be particularly contagious and harmful to babies under 6 months. All people who come into contact with the baby, including grandparents, siblings, and caregivers, should be fully vaccinated. This way they create a cocoon of protection to help keep the baby safe. And this is a slide that shows the circle of protection. All right, now we're going to talk about the each vaccine briefly and the disease that it protects against in more depth. We're going to go through the vaccines chronologically in the order that they're recommended. The first one is hepatitis B. It's important that the first dose of hepatitis B be given around birth, even before baby's discharged from the hospital. This is strongly recommended even if the mother is not infected with hepatitis B. Giving the first dose early on has been shown to increase the likelihood of a child completing the series, and also acts as an extra layer of protection against perinatal infection in case the mother's hepatitis B status is unknown or incorrectly documented. If the mother is known to have a hepatitis B infection, the baby should receive the first dose of vaccine in addition to a dose of hepatitis B immunoglobulin within the first 12 hours of birth. The hepatitis B vaccine is given as a 3-dose series, as shown on the slide, usually at birth, the second dose at 1 or 2 months of age, and the third dose between 6 and 18 months. It's important to note that only the monovalent vaccines, Recombavax and Energex, can be given at birth. There are some combination vaccines that give hepatitis B with other diseases, but those are not recommended for the birth dose. If the child does not follow the recommended vaccine schedule, they can still complete their on the catch-up schedule. So the Recombavax and Energex are single-agent vaccines that protect only against hepatitis B. There are 3 combination vaccines that protect against hepatitis B along with other things. There's the Comvax, which protects against Haemophilus influenza type B and hepatitis B, and then there's Twinrix, which protects against hepatitis A and hepatitis B. Pediarix protects against diphtheria, tetanus, pertussis, polio, and hepatitis B. And it's important to note that any of these vaccines can be used to complete the series, so you shouldn't delay or stop the series if you don't have the same brand the entire time. All are given intramuscularly, and the only contraindication to using hepatitis B vaccines is if a patient has a severe allergic reaction to a previous vaccine dose or one of the vaccine components. There's a precaution to giving the vaccine if the patient has a moderate to severe acute illness with or without a fever, or if the baby weighs less than 4 pounds. So hepatitis B itself, there are 3 different types of infection. Acute infection is a new hepatitis B infection, which may or may not have symptoms. Acute infections can turn into chronic long-term infection. young children are at highest risk for developing chronic infection, with about 90% of infants and up to half of children aged 1 to 5 becoming chronically infected. Perinatal infection occurs when an infected mother passes the infection to a newborn baby. Without vaccination, approximately 40% of babies who are born to hepatitis B infected mothers will develop chronic hepatitis B infection. Hepatitis B is transmitted through contact with infected blood or bodily fluids, or through mucosal contact with body fluids when the skin barrier is breached. It cannot be spread through food, water, sharing utensils, breastfeeding, hugging, kissing, hand-holding, coughing, or sneezing. Symptoms of hepatitis B include fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, joint pain, jaundice. But most kids under 5 won't have any symptoms, and only about half of kids age 5 and up will have any symptoms, which means that an infection can be even harder to catch in young children. About 1% of people with acute hepatitis B will die, with people over 60 having higher rates of fatality. There's no treatment for acute infection, just symptomatic treatment. The symptoms of chronic infection can range from no symptoms at all to severe liver disease like cirrhosis and liver cancer. Of children who develop chronic infection, a quarter will die prematurely. There is antiviral drug treatment for chronic infection, which also requires regular lifelong monitoring for progression of disease. Like any of the vaccine-preventable diseases, this has to be reported, hepatitis B has to be reported to the Illinois Department of Public Health and the CDC as quickly as possible after diagnosis. This is a picture and a video link to talking about hepatitis B. The next vaccine we're going to talk about is rotavirus. The minimum age, so there's 2 rotavirus doses, rotavirus vaccines, I'm sorry. There's one called Rotarix and one called Rotatech. We'll talk about those in a sec. The minimum age for the first dose of either is 6 weeks, and the maximum age for the first dose is 14 weeks and 6 days. The maximum age for the last dose of either series is 8 months old. The rotavirus vaccines have a narrower window for administration than some other recommended vaccines, so it's important that providers complete one of the 2 series within the outlined time frame. The contraindications and precautions for this, the contraindications to giving the rotavirus are severe reaction to the previous dose or component, severe combined immunodeficiency, or a history of intussusception, which is intussusception is when one part of the intestine slides onto the adjacent part. If a child has that, they're not supposed to receive a future dose of rotavirus vaccine. Precautions for giving the vaccine are moderate to severe acute illness with or without fever, other immunodeficiencies aside from SCID, chronic GI disease, spina bifida, or bladder. The recommended schedule for is similar for both vaccines, with the main difference being that the Rotatech requires 3 doses and the Rotarix requires 2 doses. And this slide goes over that. Rotavirus infection is most common in infants and young children, though adults can be infected too. Prior to the introduction of the vaccine in 2006, most children in the United States had been infected with the rotavirus by age 5. Infection occurs year-round, but at higher rates in December through May. Rotavirus particles get shed in feces and can enter, they're spread from person to person that way, and through contact with contaminated hands, toys, surfaces, food, and water. Infected people shed the most viral particles while they have diarrhea and for the first 3 days after they're recovering. Infection is self-limiting and usually lasts up to a week. Children in child care centers are at higher risk for being infected. After exposure to rotavirus, symptoms usually develop in 2 days. They include watery diarrhea, vomiting, fever, and abdominal pain. Dehydration is also a fairly common complication. Before the vaccine was introduced in the United States, rotavirus infections were responsible for more than 400,000 doctor visits and more than 200,000 emergency department visits, about 70,000 hospitalizations, and about 50 deaths every year. The vaccine is estimated to prevent between about 50,000 hospitalizations each year, and globally, rotavirus is still the leading cause of severe diarrhea in children. Causes about 500, or in 2008, caused about 500,000 deaths. There is no therapy for infection. It's treated with rehydration. This is a slide about dehydration and showing a video showing the effects of rotavirus. And a point that sometimes I'll bring up for skeptical parents with rotavirus is it's a great example of what happens when there's a legitimate concern about a vaccine. there was a rotavirus vaccine that was introduced in the late 1990s. And shortly after it came out, it was noticed that there was a slightly higher risk of this intussusception shortly after babies who received the vaccine. The risk of having intussusception is like 1 in 10,000, and the risk after the vaccine was slightly higher than that. And once that was detected, the vaccine was immediately pulled off the market. It was pretty much gone within a week or two. Not there. And it's how quickly the government acts when there's a legitimate concern about a vaccine. And we'll talk a little bit later about how those concerns get picked up. So the next thing we're going to talk about is diphtheria, tetanus, and pertussis as a DTP vaccine. There are two different types of vaccines that we'll explore. The difference between them is one is for kids under age 7, while the other is for age 7 and up. A helpful way to remember is that the uppercase letters refer to full strength dose of vaccine, while the lowercase refer to reduced strength doses. Children under 7 receive the full strength dose of diphtheria and tetanus toxoids and pertussis vaccine, so it hence the capital DT and P. And adolescents and adults receive the reduced doses of diphtheria and pertussis, so it's a little d, little p. The A in the vaccine name refers to acellular pertussis, meaning that the pertussis vaccine component contains only part of the pertussis organism. So the DTaP is a 5-dose series for 7. There are several brands, all of which are combinations against diphtheria, tetanus, and pertussis. There's the one that I see most common is Pentacell, that protects against Haemophilus influenza, polio, and then DTaP. Pediarix protects against hepatitis B, and DTaP and polio. And then there's something called Kinrix and Quadricell, which are used as the 5th dose in children that protect against polio and DTaP. The recommended dose schedule is to give them at 2 months, 4 months, 6 months, between 15 and 18 months, and then a 5th dose between 4 and 6 years. And if a child falls behind on the schedule, they can still finish the series with a minimum of 4 weeks between dose 1 and 2 and 2 and 3, and a minimum of 6 months between dose 3 and 4 and 4 and 5. But I would refer anytime you have somebody behind to the CDC's catch-up schedule, because it's very difficult to remember things like that. So the Tdap and TD vaccines are a continuation of protection for adolescents and adults over age 7. They're given in addition to the DTaP vaccine series we just talked about, and can be used to help catch up older kids who aren't fully immunized. Tdap vaccines are used for kids over age 10 and have the trade names Adacel and Boostrix. TD vaccines are used for children 7 and older and have the trade names Decavac and Tenavac. It's recommended that children receive a Tdap dose between 11 and 18 years, although it's preferred to do this on the 11 to 12-year side. TD shots need to be given to all adults every 10 years or as needed in case of exposure to tetanus. If an adolescent doesn't receive the Tdap between an 11 and 18, they should receive it as soon as possible at any age. This Tdap dose can replace one of the 10-year TD booster doses. If a child doesn't complete the DTaP series by age 7, they're not fully protected and should complete the series according to the ACIP catch-up schedule. The Immunization Action Coalition makes a table that summarizes all the DTaP, Tdap, and TD vaccine timing recommendations. I believe that's on our resources at the end. Okay. So a Tdap vaccine is particularly important for pregnant women. They should be vaccinated at each pregnancy, preferably between 27 and 36 weeks. If they're unvaccinated at the time of birth or if the vaccine status is unknown, the Tdap vaccine should be given immediately postpartum before the mom goes home. The Tdap vaccine in pregnant women has 2 main benefits. The maternal antibodies can transfer to the baby and offer some protection to the baby, and also prevents the mom from passing the disease to the newborn. Pertussis is highly contagious, and infants are at highest risk for severe or fatal complications. So it's critical to keep them protected before they can start their vaccine series. For this reason, it's also recommended that any family members or caregivers are also up to date on their DTaP and Tdap vaccination. Just a little bit about these diseases themselves. Diphtheria is a bacterial infection caused by a bacteria called Corynebacterium diphtheria. It's spread through the respiratory system, respiratory droplets, and it produces toxin that can cause, initially causes sore throat, weakness, fever, and swollen glands, and then this toxin makes the pseudomembrane that forms in the throat that can block breathing, make breathing difficult. The toxin that it makes can also get into the bloodstream and travel to other organs like the heart and the kidneys. Complications are very serious from diphtheria. They include heart muscle damage, nerve damage, paralysis, skin lesions, and lung infections. The mortality rate for diphtheria, about 10% dying even with treatment, and even more so in kids. If it's not treated, it's over half of the cases that are fatal. Diphtheria is treated with antitoxins and antibiotics. It used to be a leading cause of illness and death in children, but since the vaccine was introduced in the 1920s, there are generally no cases in the United States of diphtheria, although it does still occur elsewhere in the world. This is a picture of somebody with a swollen neck and a picture of the pseudomembrane. Tetanus is a rare bacterial infection caused by a bacteria called Clostridium tetani. The bacteria produces a toxin that gets into a person's central nervous system. There are 3 different forms of tetanus. The generalized form is the most common, about 80% of cases. It typically begins with muscle spasms in the jaw or locked jaw, and then causes muscle spasms throughout the body. Localized tetanus is when the muscle spasms are confined to the area of the body where the bacterial exposure occurred. And cephalic tetanus occurs when the bacteria enter through a lesion on the head or face. Usually causes cranial nerve palsies rather than spasms. And both localized and cephalic tetanus can progress into generalized tetanus. The bacteria that cause tetanus are present in the environment, soil, and dust, and usually enter through broken skin. Cases of tetanus have decreased by about 95% since reporting began in 1947, mainly due to immunization. They're very rare. There's usually, from what I've read, anywhere between 20 and 50 cases a year in the United States. So even though people worry a lot about getting their tetanus shot, what they should really be concerned with protecting themselves against is pertussis. And this is a picture of somebody with muscle spasm, locked jaw. The pertussis, also known as whooping cough, is the most common of the diseases in the DTaP vaccine. It is a bacterial infection caused by Bordetella pertussis. The bacteria makes toxins and other harmful substances that cause disease symptoms. There are 3 stages to pertussis illness. The first is called the catarrhal stage, which usually is like a common cold, low-grade fever, runny nose, mild cough. That usually lasts 7 to 10 days, which is followed by the paroxysmal stage, where people have severe rapid coughing fits, followed by the characteristic whoop of noise that accompanies inhalation. This whoop is not always present in adolescents and children, but pertussis still needs to be kept in mind in anybody with a chronic cough. Post-cough vomiting and fatigue are common in this stage as well. The coughing attacks usually occur on average 15 times a day and can be worse at night. And this paroxysmal stage usually lasts anywhere from a week to a couple months. The final stage is the convalescent stage, which is when recovery begins. Coughing lessens frequency and severity, but still can last for a couple months. Infants with pertussis may only have apnea as their sign, and not the characteristic coughing paroxysm. But it's important to diagnose pertussis in this population because they're most at risk for severe or fatal complications. About half of infected infants under 1 who will need to be hospitalized. The incidence of pertussis has greatly decreased since the vaccine was introduced in the 1940s, but a few years ago was the highest number of cases in decades, when there were 20 deaths. And children less than a year old still have the highest rate of pertussis of any age group and are most at risk for severe outcomes. The second highest age group at risk for getting pertussis is 7 to 10 years old. Pertussis is highly contagious and spreads through respiratory droplets from coughing or sneezing. Older or younger kids often get it from their older siblings or caregivers who have mild symptoms. Infants can get pneumonia, convulsions, encephalopathy, and about 1% of babies under age 1 who get pertussis will die from complications of it. It's important to diagnose and treat pertussis as early as possible, since it's easy to treat with a simple course of antibiotics. And it's fairly common. They say anywhere between 500,000 and 1 million cases or so a year, and it's very underdiagnosed because we see so many coughing kids and adults. We don't think about it and test for it a lot of times. But fortunately, it's getting easier to test for. And at least in our practice, if we think about testing for it, we usually treat even before we get the results of it. This is the child with some of the sequelae of pertussis, somebody with broken blood vessels from coughing in their eyes, and a baby hospitalized with severe pertussis. All right, the next vaccine we're going to talk about is for a bacteria called influenza type B. This vaccine was introduced in infants in the 1990s, and the incidence of severe Hib infection in infants and children has decreased by about 99% since the vaccine was introduced. There are several types of vaccine available. Some protect just against Hib, and some protect against Hib plus other things. You can see on the slide which those are. And you can also see intervals at which they can be given. The schedule, like with most vaccines, is pretty complex. And if you need to catch somebody up on Hib, you should consult one of these schedules here. I'm not going to go too much into how to store and to give these vaccines because so certain groups of kids are at high risk for Hib infections and have special vaccine recommendations, like kids who are immunocompromised, like kids who are getting chemotherapy or who have anatomic or functional anemia, have HIV, or have immunoglobulin deficiency. And this slide talks about how many doses those kids need if they are at higher risk for Hib and when to give them. And the contraindications to this vaccine, as with all vaccines, are the severe allergy. And the precautions are moderate or severe illness with or without fever. So Haemophilus influenza type B vaccine protects against only type B of Haemophilus influenza. There are also types A, B, C, D, or A, C, D, E, and F. Haemophilus influenza type B bacteria typically just kind of hang out in people's nose and throats and don't cause any symptoms or cause minor infections like bronchitis and ear infections, but they can move to other parts of the body and cause more serious infections. The most common types of invasive infections are pneumonia, bacteremia, and meningitis, but also epiglottitis, cellulitis, and infectious arthritis. Children under age 5 still experience the highest rate of infection, even though it's very rare to have severe Hib infection at this point. And it's transmitted from person to person by respiratory droplets. Prior to the introduction of the vaccine, about 20,000 children a year under age 5 got invasive infections, and 1,000 of those died in the United States every year. Fortunately, we're seeing a lot less now. And this is some information on symptoms or cases of Hib infection. The next vaccine we're going to talk about is against pneumococcal disease. We're going to talk about the PCV13 vaccine, otherwise known as the Prevnar vaccine, which is given as a 4-dose series, 2 months, 4 months, 6 months, and then the 4th dose is 12 to 15 months. That protects against 13 strains of bacteria Streptococcus pneumonia. There's also a vaccine that protects against 23 strains, and that's only given to kids age 2 and older who have certain underlying conditions that put them at high risk for invasive infection. And which those conditions those are is outlined through the link on this slide, as is the catch-up schedule if you're missing doses. This slide goes over the storage and contraindications. So pneumococcal disease is a bacterial infection caused by strep pneumonia, which can cause, it's a common cause of bacterial infections like bacteremia, pneumonia, meningitis, and also middle ear infections in young kids. Pneumococci cause invasive disease when they travel to sites of the body that are normally sterile, like the blood, lungs, brain, cerebrospinal fluid. Invasive pneumococcal disease is a nationally notifiable disease. Prior to routine vaccination, pneumococcal disease took a serious toll on kids under age 5, causing 13,000 cases of bacteremia, 700 cases of bacterial meningitis, 5 million ear infections, and 200 deaths yearly. Vaccination has greatly improved these statistics, but some groups of kids are still at higher risk, like kids under age 2, those in group care, those with sickle cell disease, HIV, or chronic heart and lung conditions, those with cochlear implants. An estimated about half of school-age children have strep pneumonia just as a normal colonization of their normal respiratory flora. And it's unclear why those don't cause disease, but that's the reservoir from which the bacteria can spread to other kids and cause disease. And the bacteria is spread through respiratory droplets. So the symptoms and complications of the most common forms of pneumococcal infections are on the slide. Complications can be severe or deadly, as I mentioned before, and any invasive infections have to be reported. This is a slide with a video link with information about complications of pneumococcal. The next vaccine we're going to talk about is polio. I'm not going to spend a lot of time on this because it has been eradicated in the United States since the 1990s, but it is still recommended to be given because it exists elsewhere in the world. It's a 4-dose series. Give it at 2, 4, 6 months, and then again at 4 to 6 years. Polio, like I said, I'm not going to spend a lot of time on because hopefully most of us will never see a case of it. The paralysis from polio is the rare form. The most common symptoms are just respiratory or GI symptoms, but and many people don't have any symptoms. But it can cause paralysis and death, which is why we still vaccinate, especially since it exists elsewhere in the world. And there's some videos here, pictures here of people affected by polio. All right, the next one, which we should all be thinking about now, is influenza. The United States has a universal recommendation that everyone aged 6 months and older receives the influenza vaccine every year. And there are virtually no contraindications to the influenza vaccine. A patient with moderate to severe acute febrile illness should usually not be vaccinated until their symptoms have gotten better. Moderate or severe acute illness with or without fever is a precaution but not a contraindication. Guillain-Barré syndrome within 6 weeks of a previous dose is considered again to be a precaution but not a contraindication. And egg allergies, which were once considered to be a contraindication, are not any longer, and we'll talk about that a little bit. The Immunization Action Coalition publishes helpful screening checklists that you can use for each patient to ensure that they don't have any contraindications to influenza vaccine. So children between 6 months and 8 years of age may need 1 or 2 doses, depending on the algorithm diagram here. If a child has received 2 or more total doses of the trivalent or quadrivalent flu vaccine before July 1st, 2015, then they get 1 dose. I'm sorry, July 1st, 2016. They should get 1 dose in the 2016-17 series. The 2 or more doses prior to July 1st, 2016 don't have to be from the same flu season or even consecutive flu season. So if they're under 9 years old, they've ever had 2 total doses of flu vaccine, they only need 1 for this flu season. If they have not received 2 doses prior to July 2016, or if their immunization history is unknown, they should have 2 doses at least 4 weeks apart. Flu season varies slightly each year, but can start as early as October and end as late as May. Flu activity typically peaks between December and February. Healthcare providers should offer vaccination as soon as it becomes available. This is because it usually takes about 2 weeks for a vaccinated person to develop the antibodies needed to protect against flu. So early vaccination ensures protection for the whole season. And you should also offer this anytime during routine healthcare visits or hospitalizations, and vaccinate people through the entire flu season, since flu virus may be circulating all the way until almost summer months. So there are, this year, there normally, up until now, there have been 2 types of vaccine, an injected vaccine and a nasal vaccine. This year, the nasal vaccine or the live vaccine is no longer recommended as of this year. So there is only the inactivated influenza vaccine with the shot. There are shots to protect against 3 strains and those to protect against 4 strains. But there's also ones made with recombinant DNA. That's called flu block. There's one made with cell culture, inactivated cell culture, that's called Flucelvax. There's a high-dose trivalent vaccine called Fluzone High Dose. So there's a bunch of different forms. So the bottom line is there's no nasal spray this year for the flu vaccine. Okay, moving on here. So the annual vaccine protects against 3 types. There's 3 types of flu virus that goes around, but only type A and B cause seasonal epidemics. Influenza A causes moderate to severe illness in any age group. It can affect humans and some animals. Influenza B typically causes milder infections that primarily affect children. It can only affect humans. And influenza C causes mild respiratory illness and is not thought to cause epidemics. Every year, an estimated 5 to 20% of the U.S. population is infected with influenza, and it can occur across all age groups. But young kids have the highest rate of illness. It spreads through respiratory droplets, and symptoms include fever, chills, cough, sore throat, runny nose, muscle aches, fatigue, vomiting and diarrhea sometimes too. Most people will recover in anywhere from a few days to a couple of weeks, but some can get severe complications, especially the very young and very old, and those with compromised immune systems. In the last flu season, there were about 65 hospitalizations per 100,000 people. That's highest in people age 65 and older. The second highest rate of hospitalization occurs in kids aged 0 to 4 years. And every year, anywhere from a few dozen to a few hundred people die from flu-related complications. The picture on the left here shows a still of respiratory droplets that are released when somebody sneezes. If that person's infected with influenza, they can travel and infect many more people. The photo on the right shows an emergency hospital set up to deal with the 1918 flu epidemic. So as I mentioned before, the new recommendations for this season, no nasal spray. There is this new Fluad vaccine that was licensed in 2015 for those age 65 and older. It has an adjuvant in it, which is an ingredient that's added to make a stronger immune response. And the recommendation for vaccinating people with egg allergies has changed. There's no recommendation anymore to observe egg allergic recipients for 30 minutes after vaccine. But they say that providers should consider observing all patients for 15 minutes after vaccine to decrease the risk for injury should somebody faint after the vaccine. So that's difficult to implement, but it's still a recommendation, but not a requirement. Also, it's recommended that people with a history of severe allergic reaction to eggs, like anaphylaxis, should be vaccinated in an inpatient or outpatient medical setting under the supervision of a healthcare provider who is able to recognize and manage severe allergic conditions. So it's okay to give it to them, just be prepared. Again, we talked about the lack of recommendation for the nasal spray. That's simply because the last few years, it's been shown that it was not very effective. So next, we're going to talk about the MMR vaccine, protecting against measles, mumps, and rubella, known by the trade names MMR2 and ProQuad. ProQuad also protects against chickenpox virus. These are live attenuated viral vaccines. MMR is usually given as 2 doses between 12 and 15 months as the first one, and the second one between 4 and 6 years. It's given subcutaneously. There's contraindications and precautions there. It protects against measles, mumps, and rubella, all of which are frequently uncommon. Measles, occasionally, or pretty much every year, there's some outbreaks of measles. Some years are worse than others. But it's estimated that about 20 million people worldwide are infected annually with measles. It's just not very common in the United States, although it definitely appears in pockets where there are under-vaccinated people. A few years ago, there were almost 700 cases in the United States. Measles is a super contagious infection spread by respiratory droplets and causes fever and rash, but can also cause more severe complications in anybody, but especially in children. It can cause meningitis, it can cause pneumonia, ear infection, and this is a picture of the characteristic measles rash. Mumps, we don't really see a whole lot, although it's something that we still, at least I still see in general practice, maybe a couple times a year. There's been a 99% decrease in the cases of mumps since the vaccine was introduced. And usually there's somewhere between a few hundred and a few thousand cases of mumps reported in the United States every year. Mumps is also a contagious respiratory virus that spreads in the way that respiratory viruses usually do. Not everyone who gets mumps will have symptoms. Those who do, they usually start anywhere from 16 to 18 days after they get exposed, and include fever, muscle aches, and the characteristic swelling of the parotid gland. Most cases recover on their own, but there are some severe complications, including inflammation of the testicles, ovaries, and meningitis. It used to be a common cause of deafness before the vaccine was available. Mumps cases, like all of these, have to be reported if they're diagnosed. This is a picture of somebody with mumps. Rubella, or German measles, is another virus that causes a fever and rash or no symptoms in most people who are exposed to it. But if a mother who's not immune to rubella is pregnant and gets exposed to it, there's a fairly good chance that the unborn baby will contract this congenital rubella syndrome, which is a devastating multi-organ affected disease that leads to short lots of complications and usually early death. And the main reason why we still vaccinate against rubella is to protect against congenital rubella syndrome. And here we can see the rash for rubella, which looks like every other fever and rash virus. Concern that, and we're going to talk about this hopefully in a few minutes, is whether the MMR vaccine causes autism. I feel like it comes up less now because at this point the research has been done. I usually tell patients it's been researched to the point that it's not even a question anymore in the medical community. Not that it ever really was a legitimate question, but at this point it's kind of been put to rest that MMR and autism are not linked beyond any doubt. It's not, like I said, it's not even something that's really looked at anymore. And we'll talk about that in a few minutes. The next vaccine we're going to talk about is varicella, of which there are Varavax vaccine and then Proquad, which were varicella is given with MMR. It's given like MMR as 2 doses. The first dose between 12 and 15 months, and the second dose is 4 to 6 years. And here we can see the catch-up schedule and the contraindications and precautions. So varicella is also known as chickenpox. It's a primary viral infection caused by the varicella zoster virus, but the other infection that causes is shingles, where the virus reactivates at a later age. The varicella zoster vaccine was introduced in 1995, and prior to that, there were about 4 million cases annually in the United States with about 150 deaths. Since the vaccine has become available, the number of cases and hospitalizations due to chickenpox has decreased by more than 90%. Chickenpox is super contagious and causes the characteristic blistery rash that scabs over, but can also cause complications in high-risk patients. Like, it can also lead to bacterial superinfections, dehydration, encephalitis, and other things. The picture of the characteristic chickenpox rash. The next one we're going to talk about is hepatitis A. Usually given as 2 doses, 6 months apart, between 12 and 24 months. There are 2 brand names for this, Havrix and Dasta, both contain inactivated virus. And then there's Twinrix, which is a combination of hepatitis B. Like I said, there has to be 6 months between the first and second dose, and you can catch up any older people, older kids, with giving 2 doses that are 6 months apart. Hepatitis A causes acute liver infection that's self-limiting and doesn't become a chronic infection. There's been a 95% decrease in cases of hepatitis A since the vaccine was introduced in 1995, but it still causes several thousand cases every year. Hepatitis A is highly contagious and transmitted via the fecal-oral route or exposure to contaminated foods or water, and sometimes there are outbreaks from contaminated foods in the United States. Symptoms, most kids who are younger, kids under 6, have no symptoms at all, although most adults who get infected will have symptoms, including nausea, fatigue, abdominal pain, vomiting, joint pain, and jaundice. Symptoms usually last less than a couple of months, but some people have relapses for up to 6 months. Almost all infected people recover without complications, but there are people every year who die from hepatitis A, and there is no treatment for it. This is a video about hepatitis A. Now a little bit about the HPV vaccine, which there are 3 vaccines that protect against. There's Cervarix, which is protects against 2 strains of HPV that cause 70% of cervical cancers. And then there's Gardasil, which protects against now 9 strains, the same 2 strains of Cervarix plus 7 other strains that cause more than 90% of cases of genital warts. And Gardasil also protects against anal, vaginal, and vulvar cancers. HPV is given as a 3-dose series. Usually started, it's recommended as young as 9. We usually started at around 11 or 12. They're given, like hepatitis B, the second dose is given a month or 2 after the first dose, and the third dose is given 6 months after the second dose. And if somebody hasn't started it at 11 or 12, they should start it as soon as possible. It's recommended for men up to age 21 and women up to age 26. And ideally, you want to start this before kids start to become sexually active. So this is just some information about HPV and the symptoms that it causes. Usually asymptomatic, but it is the main cause of cervical cancer, which is a deadly type of cancer that is often diagnosed too late for there to be any successful treatment. Or a video about HPV. I like this, that you're not opening the door to sex, you're closing the door to cancer. Good slogan for HPV. I feel like more parents are, now that it's been around for 10 years or so, parents are not nearly as resistant as they used to be. Although, as pediatricians, from what I've read, we do not the best job of vaccinating people on time for this. Last vaccine we're going to talk about is the meningococcal vaccine. There are a couple different types. The first we're going to talk about, there are 2 quadrivalent vaccines that protect against the Neisseria meningitis type A, C, W, and Y. These are called Menactra and Menveo. And then there's something called Menhibrix that protects against the C and Y strains as well as Haemophilus influenza type B, but that's not used very often. The recommendation for vaccination for the Menactra or Menveo vaccines is to give it 1 dose at 11 to 12 years, and then a booster at age 16. It's also recommended that kids aged 2 months to 18 years who are at high risk for getting meningococcal disease get vaccinated against it. There's a link on the slide here that shows who should get that. There are also 2 FDA-approved vaccines for the B strain of meningococcus called Bexsero and Trumemba. Bexsero is given as a 2-dose series and Trumemba as a 3-dose series. These vaccines are not interchangeable, so you're supposed to stick with one type to finish the series. And the ACIP recommends that anybody aged 10 or older get these vaccines if they're at high risk for infection with the B strain. So that's kids with anatomic or functional asplenia, complement deficiency, or those who have been exposed during an outbreak, and microbiologists who work with Neisseria meningitis. Trumemba, a lot of you probably saw during the Olympics, had an extraordinarily effective vaccine campaign, ad campaign, where I've never seen so many people coming in asking about a vaccine. But it's not routinely recommended for most patients. These slides just kind of talk about how to store the vaccine, how common meningococcal meningitis is very uncommon, but it's extraordinarily deadly. And teenagers and college-age kids tend to be most at risk of this. So that's who we're trying to protect, save the totally healthy kids, especially you hear about in general practice, you hear about every couple of years, kid goes off to college and gets terrible disease. Hopefully we'll be seeing a lot less of that. Now I want to spend our last 15 minutes or so going through some of the more common concerns that we get in general practice. The first one being, does MMR cause autism? Like I said before, the answer is an unqualified no. It never really was a legitimate concern in the medical world, but the way it came about was a doctor in England named Andrew Wakefield published a case report. It was not a study, it was a report on 12 kids or so who he saw. He was a GI doctor in England, and he saw kids who got the MMR vaccine, and shortly after, their parents or their doctors or people who knew the kids said that they developed developmental symptoms that were similar to, but not the same as autism. He said maybe there's some link between MMR and autism, and he published in a reputable journal. He said in these 12 kids, I did biopsies on their intestines, and we should maybe think about if there's a link between MMR and autism. This was portrayed in the media at the time as MMR causes autism. Does the MMR cause autism? Once you say that, it became very hard to unring that bell. Abundant research since then has shown that there is no link between MMR and autism, to the point that it's, like I said, it's not even a question anymore. These are just a list of study after study, big studies that show that there's no link between MMR and autism. What is autism is a talk for a different time, but when I talk to parents about this concern with autism and vaccines, I try and talk about what autism is. A lot of parents really don't know what they expect. That autism is going to be, these severely impaired. I think most people have like the Rain Man type of thing, or they have like severely impaired kids who have to be institutionalized. And that when we used to talk about autism, and still kind of do, there's a huge range in autistic symptoms. And so when you read numbers like 1 in 80 kids have autism, it's not 1 in 80 kids that are severely impaired. There can be what we used to call autism could range from severe impairment to just a difficult toddler could be diagnosed on a bad day as having autistic spectrum disorder. Now, the criteria for diagnosing autism have changed within the last couple of years, and we're seeing that autism is less commonly used as a diagnosis, but that's just shifting kids with mild symptoms into other categories, speech delay or developmental delay or learning disabilities, things like that. So when I talk about vaccines and autism, I talk about what is autism, that the symptoms usually appear at an age when kids are still getting their vaccine, but that does not necessarily, it doesn't mean that they're related. And then I talk about what we know about autism and what possibly causes autism. We know there's a genetic component to it. Maybe there's an environmental trigger. Nothing specific, no large exposure environmental trigger has been identified, but vaccines have been studied more than anything else and shown not to be a cause. When I give talks on vaccines, there can be sometimes people there who want to know, sometimes I've given talks where they wear shirts that say, where are the studies? Show me the studies. And the studies are there. There is a book that the Institute of Medicine, which is a non-partisan, non-profit group, it's an international group that kind of looks at any scientific question put to them, was asked, what bad effects do vaccines cause? And they put out this book that came out in 2011, which you can get online, that looks at, in detail, at all available evidence, thousands and thousands and thousands of studies, and concluded that vaccines and MMR specifically, but vaccines in general, do not cause autism. Anyone who wants to see the studies should take a look at this book. People will sometimes have this feeling that like the vaccine schedule comes from a group of people in a dark room in a cave somewhere that, you know, like how can we maximize our profitability off of injecting kids? And the vaccine schedule is a very transparent process. This advisory committee on immunization practices has 15 members. They're appointed by the Department of Health and Human Services. There are members from there is a member from the general public. There are many subcommittees. They meet several times a year. All of their meetings are open to the public, and the transcripts are published online. And it often takes decades once the vaccine gets, from the time the vaccine gets proposed to the time it gets approved, often takes decades. So people who have this impression that vaccines are rushed out as a money-making thing, I tell them it takes decades, 10, 20, 30 years sometimes. And that vaccines, for the most part, are not a profitable venture for drug companies. Drug companies would make way more money giving the drugs to treat vaccine-preventable diseases than they would by giving vaccines. It used to be people would ask about separating the MMR vaccine. This isn't done anymore, and there's no reason to do it. So fortunately, it's not a question that I get anymore. Every once in a while, there's something called the Vaccine Court that was started in 1998. It's funded by a tax on vaccines. And it's a court of special judges that are appointed just to hear vaccine injury-related cases. And there are sometimes cases where it's shown that vaccines may have caused problems. Like usually it comes out that somebody with like a mitochondrial disorder, where a kid can have developmental regression triggered by any large stressor, has the regression shown to start shortly after they get vaccine. And the vaccine court show you don't have to show beyond a reasonable doubt. You just have to show that it was possible that the vaccine caused injury. And in those kids, even though they could have gotten sick and that could have been the stressor, the vaccines also could have been the stressor. And the vaccine court is designed to compensate people who could possibly be injured by that. But even that court has shown that there's no link between MMR, thimerosal, which is a mercury-based preservative, and autism. Are vaccines safe? If safe means harmless, then no vaccine is 100% safe. There's always going to be the very rare 1 in a million things that you can't prove are related to vaccines, but certainly could be possible. But very few things in life are harmless. People die every year getting struck by lightning. People die coming out of the bathtub. If safe means preserving from a real danger, then they're very safe. For all vaccines, the benefits far outweigh the risk. I talked about how quickly vaccines are pulled when there's a true concern. And there is a system in place, it's called the Vaccine Adverse Events Reporting System, where anybody can go online, parent, patient, clinician, neighbor, can go online and look at people who report potential bad effects of a vaccine. And that's what the government monitors to look for things like what Vaccines, are they necessary? They're a victim of their own success. Most people have never seen a lot of these diseases that vaccines prevent. But they're given because some diseases are so common that not immunizing puts kids at risk. Some diseases are there at low levels that if you don't immunize, you're going to lead to outbreaks. And some have been virtually eliminated, but if you stop vaccinating, they're going to come back. Infants are not too young to be immunized. Their immune systems are fully ready to go from when they're born, and infants are much more likely to get a lot of these infections. People a lot of times worry about their babies are going to get so many shots. They don't want to get so many shots. One good thing about the combination vaccines is that really the most number of needles that somebody would get on a given day is 4, and even that's pretty uncommon. It's usually more 2 or 3. But babies are exposed to millions of germs every day. From all the shots that they get even today, at the most they're going to get maybe a couple hundred different proteins that their immune system's going to have to react against. A single bacteria on a toy can make over 3,000 different proteins. It can cause the body to make over 3,000 different proteins. So when you're giving shots, you're literally it's a drop in the ocean for your immune system. Definitely not better to get naturally infected. It may be better for your immunity, but it can make you a lot sicker. Vaccines do not weaken the immune system. The viruses and bacteria and vaccines are so disabled that they can't weaken it. This idea of delaying or staggering shots, or the SEER schedule, is unfortunately comes up for a lot of parents, and it's really frustrating to deal with. Although even he's being discredited now. He is a pediatrician who wrote a fairly popular book where he kind of outlined all the vaccines and then came up with this schedule, his own schedule that he had to buy the book to get, which had no scientific backing behind it. Found out when we were doing it in our office, when we were doing what parents wanted, all sorts of missed vaccines and over vaccines. People ask about should vaccines be greener. There are many things in vaccines, but they all serve a purpose. You don't add things to vaccines just to do it. Thimerosal, when parents ask about that, I know they haven't really even done the basic amount of research because it hasn't been used in vaccines for almost 20 years. Aluminum, there's way more aluminum in formula and breast milk than there is in vaccine. Formaldehyde, but there's formaldehyde in your body. And then I always encourage patients to read the vaccine information statement. We give those out at our office. Prepare questions before the visit. Bring their favorite toy, blanket, book, and to stay calm because kids can sense. I can tell you what parents going to page me at night because their kids crying about vaccines before they even get their shots. I think any pediatrician can probably pick out those. The more anxious you are, the more likely the baby's going to have a hard time with it. Our problem is that nearly half of kids are under-vaccinated at some point, and 1 in 8 are under-vaccinated due to parental choice. So we have to learn more about the consequences of these decisions and counsel parents. Our recommendations matter the most. We want to vaccinate on time, every time. Explain why we vaccinate. Be patient with patients. Ways to improve vaccine rates in general, to have reminder and recall systems, which electronic records make much easier to do. Make sure the parents know and that staff know it's safe to get multiple vaccines. Try not to spread out or delay vaccines. And that it's okay, 90% of kids we see this time of year until May are going to have at least a runny nose. So it's okay to give during ear infections, colds, while taking antibiotics. I think we made it with a couple minutes there. So, all right.
Thank you, Dr. Goldstein. So we have about 2 minutes or so for question and answer. I don't see any questions right now, and I think, Dr. Goldstein, those last 15 that you went with are a lot of commonly asked questions. So that was wonderful. Thank you. And once again, I just want to let people know that if you do have any questions at all, you submit them on the right-hand side of your screen into the control panel for GoToWebinar. So if anybody does have any, just put them in right now and we can quickly go over that. But if not, I can go ahead and wrap up the webinar. So I'll just go over a couple final housekeeping items then, just to see if anybody does submit any questions. I just wanted everyone to know that we are offering continuing education credit for this webinar, and everyone should receive a link to complete an evaluation sometime tomorrow, and you guys will also receive a copy of the PowerPoint and a recording to view today's webinar. And if you do come up with any questions at all that you have after this webinar that you just forgot to ask right now, feel free to email it to me. This is Ann Wong from ICAP, and I will try my best to get that answered for you. So it doesn't look like we have any questions, so I'm going to go ahead and close out the webinar completely right now. So I just wanted to thank Dr. Goldstein again for his wonderful presentation, and I also wanted to thank IPHA for working with us to co-sponsor this webinar. So thanks again to everyone for joining us today, and I hope to see you guys on one of our future webinars. Thank you so much. Everyone have a great day. Bye.
Thanks.
Thank you again, Goldstein.